Good afternoon, everyone. Thank you for joining us again for another one of our Facebook Live sessions. My name's Wendy Randall. I'm one of the consultant midwives in Oxford, and with me I have Nikki Wiggins, who is midwife of many roles, but has been a community midwife for a long time. So she's going to take you through what happens when you're in established labour, because Sarah went through with you those early stages yesterday. Before we move on to the session, I just wanted to make a plea to people that if you think that you have a problem, if you've had any bleeding or anything that you're not sure of, or when you think you're in labour, please can you give us a call. We think people have been putting off calling us because of what's happening with COVID. We really do think it's important for some women that we see you, and believe us, we have cut our pathway right down so that we're only seeing you when we really need to see you. So please do attend your antenatal appointments if the midwife has told you they should be face-to-face. And please do call places like our maternity assessment unit or our maternity assessment centre in Banbury for advice. The midwives are there to support you, and they will advise if staying at home is the right thing or whether we should see you in hospital. Because we think there's potentially some people out there that should be being seen and aren't seeking our advice and support. So that's my plea for today. And now for the fun stuff. Nikki's going to take you through labour.
Hi everybody, thank you for the introduction, Wendy. I hope you appreciate, it's a little bit nerve-wracking doing it this way because we're so used to teaching a class. But what I'd like to do is just take you through the labour, starting perhaps with the first stage of labour, and if we have time, progress through to the end of labour. But if we don't manage to reach that because there's lots of questions coming up, then we'll continue that on another occasion. I'm sitting in the spas at the moment, but I want to try and apply this to wherever you have a baby, be it at home, in the consultant unit or any of the other midwifery-led units. A lot of you probably are doing a lot of reading, or may well do a lot of reading, and the stages of labour are sort of the most common way everything is talked about. But I wanted to sort of try and describe labour as more of a continuum at the moment today, because it's there are discrete sections, and I'm going to describe them to you. But women travel the journey of their labour in different ways at different speeds and times. So some of the things that you'll read about aren't actually set in stone, and that's what your midwife is for. You're going to have your own midwife for most of your labour, and she's there to support and advise you. She will have looked after many people in labour and will be able to give you reassurance where it's needed, or if there needs to be advice sought from a doctor, she will seek it at the appropriate time with discussion with you. So try not to take time at times as absolute, because it can be quite different, and it depends on the whole picture, how we judge things. So your midwife and your partner will be there with you. There are shift changes, obviously. We do mostly long shifts, so we do 12-hour shifts. So if you're lucky enough to come at the beginning of somebody's shift, you'll have one midwife, that same midwife, for all of your labour. Obviously, some people have a change in midwife, and you do form quite a close relationship with her. But it can be an opportunity when the shift change comes on for a new, fresh eyes on things, somebody with more energy to take you through to the end of the labour, rather than a midwife that perhaps has been there for 12 hours. So people worry about having a change of person, but we're all geared as a profession to work with you, to form a relationship with you, and we work together, everybody looking after you, to get through the labour safely. So the first stage of labour, I think you started yesterday with Sarah, talking about that early, what we call a latent phase of labour. The active phase of labour we would usually describe as being when your cervix has probably reached 4 centimetres, which when you're looking at someone is very difficult to see. And also sometimes we have to consider what's happened before to make a sort of bit of a judgment call when we might think labour had started. So we would usually suggest it's 4 centimetres. The end of the first stage of labour is when there is no cervix left. If we're feeling and doing vaginal examination, we would notice that, or perhaps your baby has descended lower, and actually it's easy to see the baby from the outside. If we can do that, then there's definitely no cervix left. The third stage of labour begins after the baby's birth, and that's for the delivery of the placenta. And after the placenta is delivered, we now look at another stage called the fourth stage. It sometimes gets called the golden hour. It's really a period of bonding with your baby, your body readjusting itself after its exertion. It's perhaps rehydration for you. It is a time that you and your husband have with the baby, and it's a very special time which we try and preserve here in Oxford. As we see it, it's very important. So the first stage of labour, if you want some figures on it, will usually be about 12 hours, 12, 14 hours if it's your first baby, if it has steady progress. But people have very short, much shorter labours, and sometimes the labour is more prolonged for different reasons and stops and starts a bit. So that gives you a sort of rough guide. If it's your second baby, your body's done it once before, and quite often that will be about half the time perhaps, or again, it can be very different. You can have a very long first labour, and with your second baby, it's very quick. So we really take notice of what's actually happening in your labour and listening to you. Those that have quite a swift first labour, it's one of those things when you're ringing the maternity assessment unit or the community midwife team, it's useful to emphasise how short that labour was, because it would probably change the criteria we'd use for asking you to come in. That doesn't mean that you might come in and there's a false alarm, but we always probably play on the safe side of things. What's actually happening in the first stage of labour? I think you may have talked about the effacement of the cervix. That's what's usually happening in the latent phase. Your cervix isn't like a sliding door that opens. It has some length to it. So before your cervix will open very wide, the contractions will be shortening that cervix, so getting it nice and thin. That should mostly be happened, especially if it's your first baby, in the latent phase. Sometimes those of you that have had babies before, it's a bit more simultaneously. The cervix will open or dilate at the same time it effaces. So there are sort of different ideas and different criteria with different women. Also, what's happening during this labour is the baby's head rotating and descending and also flexing. I think Wendy alluded to that. And I have a pelvis here. Just ignore the questions. Yeah, I can't see them anyway. I can't read the questions without my glasses, so that's fine. So we have a pelvis here, and I think there were some questions yesterday about the pelvis and which way the baby goes down. And Wendy was explaining that the babies often come sideways, so their back will be either there or there. And as you can see, that's fairly logical because the shape of the pelvis is a bit more like a heart shape at the top. So the back naturally goes towards the side to go in at the widest angle. In the middle of the pelvis, it's difficult to see, but it's circular, so the baby has time to manoeuvre. And obviously within the pelvis, there are ligaments and structures that actually encourage that baby to rotate. And then somebody was mentioning coccyx pain. I'm trying to get this sideways on so you can see. So as you can see, there's a bit of a curved, it's difficult to do it backwards. There's a curve to the pelvis, so that's the sacrum. And this little bit here is the coccyx. And we've got that as mobile because it's mobile in you too. As the baby descends through to the outside world, this coccyx will move backwards out of the way. And it can feel a little bit bruised after delivery sometimes. Sometimes babies can be leaning this way, and maybe that's sometimes some discomfort there, but more commonly you don't feel discomfort down there. So what drives this? So we've talked about contractions, and I know somebody was asking about what a contraction feels. Unfortunately, I haven't had a baby, so I haven't experienced a contraction. But often you find when people are asked, even when they've had babies, to describe contractions, it all becomes a bit fuzzy because memories are a bit funny if you haven't got that pain there at the time. But what I do know is that it's extreme discomfort, normally at the bottom of your tummy, or it can be in your back or down your legs. And sometimes it moves during the contraction. it will change. It will start perhaps in your back and come to your front. It's different for different people. But what we do know is that the pain increases in intensity, reaches a peak, and then goes away. And then in between the contraction, you actually aren't in any discomfort at all. So I've got a bit of a poster here. It's one I use when I teach my students upside down. So if you were looking at a monitor, you'd be seeing these peaks going up and down here. Usually in established labour, that you'll find that the contractions will be, the momentum will be forward. You'll be noticing that the contractions will be lasting longer, they'll be getting stronger, they'll be getting closer together. So ultimately, people tend to have a contraction lasting a minute, about every 2 or 3 minutes towards the end. And that's a really positive thing, that these contractions do get stronger, because they're going to help deliver your baby. It's much easier to work with when the contractions are being quite efficient. But what's driving these contractions is a hormone called oxytocin that's produced. It's actually produced in your head and travels to receptors on the uterus and makes the muscle contract. And it contracts in a particular way so that the cervix is drawn open and the uterus shortens. Oxytocin is often called the love hormone, apparently. But what it does is to help make you calm, happy as well in your labour. It's generated in response to the head pressing against, or the baby pressing against the cervix, and also the sense of the baby being on the pelvic floor. So that helps generate and increase the oxytocin. So as the baby descends, the oxytocin is produced more, and then the contractions get stronger. Those of you having Braxton Hicks, especially towards the end of your pregnancy, may notice them getting stronger, and that's usually as the receptors are building up. But the trigger for the labour to start is really not known a lot about. There's some thoughts around prostaglandins and things, but that trigger to go can be still a mystery. But we know that oxytocin is the driving hormone. There are also things called endorphins in your body. Again, these are hormones that your own body's painkillers. So these are what the body produces in response to stress and pain. So as you travel through your labour, your body's going to produce hormones to actually help you cope with what you're feeling. And I think Telemetry Machines, for those of you that want to read up about it, they are, one of the ways they work is to increase the endorphin production, and the other way is to sort of just block the sensation, or distract you from what's going on. I think Wendy's going to try and find a Telemetry Machine, because I know they wanted to find one for you. Another hormone that plays a part in labour is adrenaline. Adrenaline is the fight and flight hormone that protects us when there's in danger. It's quite a primitive hormone, and this has the effect of damping down the oxytocin in your bloodstream. So it's not very helpful in your labour. So we do everything in our power to reassure you and keep you away from your fears. We often see the effect of this adrenaline is when you come into hospital. On the phone, you might have described having very frequent contractions, but when you come into the labour ward, the contractions aren't as frequent, and people often apologise, saying they were much stronger at home. And yes, they probably were, but it's just that adrenaline build-up from coming into hospital and being in a strange place and seeing where you are. But there are things that we can do to help you. How you can help yourself is trying to stay calm, comfortable and confident. You can help yourself by preparing with some knowledge, perhaps trying hypnobirthing or mindfulness, preparing your companion. Your birth companion can be really a positive influence. As I said, the relationship with the midwife will also create this calm atmosphere where you have confidence in those people around you. Keeping yourself hydrated, we've talked about this before, things like isotonic drinks, perhaps freezing some bottles of water and bring them in, some squash and things, sometimes with slight bit of sugar for those that aren't diabetic. Having nourishment, so small snacks, your body probably won't digest terribly well, so keeping them small and nourishing, so often carbohydrate-based things are good. Keeping active in labour is also important, and we have, you use you go, when you go into your labour room, you can create your room becomes your own. So the bed might seem like it's quite a dominant bit of the room, but the rooms are quite large. And over my shoulder, you see we have bean bags in each room, and we have floor mats to encourage you perhaps in a kneeling position, but walking around is excellent. There is a birthing stool behind me. People might use that perhaps in the second stage, but you can mimic that sort of position at home where something's more comfortable. We kneel quite a lot. The beds convert into different shapes to support you. It's still important to have a rest if you're very tired as well, but just changing the change as the body moves. Your body will perhaps tell you where you're most comfortable. If you get perhaps fixed in a position that some people get very set, they've got a set pattern with how they cope with the contraction. But actually, sometimes you do need to make the changes. So keep your bladder empty. Try to focus on what's happening at the time, because often you miss that gap in the contractions where you haven't got pain. Use that time for perhaps making contact with your partner, perhaps just resting, having a drink, just enjoying that moment rather than thinking about what's just happened or the contraction that's about to start, because it's a very replenishing time where you can refresh yourself, ready for the rest of your labour. Obviously creating a positive environment I've talked about. So we keep the lighting low if you want the lighting low. If you'd rather the lights on, that's fine, it's your own room. Some people bring music in, familiar objects. We talked about pillows. Sometimes I've had people with perhaps a picture that depicted a walk up a mountain, something that was quite challenging to keep them focused on. I think you've got a TENS machine, haven't you? Mm-hmm. These TENS machines, you can buy them on eBay, but you must make sure that you have new pads. You must make sure it's designed for childbirth, because TENS machines are used for sports injuries and the settings on the machines aren't for labour. You can hire them through different chemists or online as well. So each comes with 4 pads, 2 sets of cables, and then you'll have a box. There's a dial that controls the strength of the stimulation for each pair of pads. Do you want to stand up? They usually come with quite good instructions. People come with pads everywhere, but what is recommended is one either side, equidistant, either side of the spine, around the bra level. And the bottom 2 pads go on the lower back. And if you look at somebody's back, you can almost see a small dimple at that point. It's where the nerves come out that go down the leg. So at that point, you put them there. Obviously, they can be moved, so if you find it's not helping or you want it slightly different, you can remove them again. So once you've got your pads in place, turn the machine on. It's a huge mistake. You only do once if you have the machine on when you're handling the pads, because your fingers are very sensitive, so it gives them quite a jolt. So the idea is you have a background sensation that's almost unpleasant in itself. And then a lot of the machines will come with a boost button. I recommend you choose one of the ones if you're going to have a TENS machine with a boost button, so that when you have a contraction starting, people press the boost button, go into their breathing, perhaps the positions they're in, and then as the contraction's on its way out, when you start feeling quite relieved, you let the boost button come off. So you can use those as long in your labour as you want to. Often people have them on and they've still got them on after they've had the baby, because they're there. They work well with some people. Other people don't find them very helpful. They're very good for backache, but and some people find them really handy. Other people don't like them, and it's very difficult if it's your first baby to know whether it's something that you would want. But do have a read about it. So you're in your labour room. You're in the active part of your labour. The midwife and your partner are there. We keep a close watch on you during your labour. So as far as mums are going, we do monitor your temperature, pulse, blood pressure, respirations, because we need to check that you're working, you're coping okay with the labour. not developing any infections perhaps, or getting too dehydrated. We also keep an eye on the babies through different monitoring methods. Now, if have no risk factors, you're in labour by yourself, then we would listen to the baby using the Dopplers that you'll all know from antenatal clinic. Now, we listen in a specific way and a specific time. The last thing you might want after a contraction is somebody putting this gently onto your tummy. We try and be discreet and as careful as you can, but the most important time for us to listen is after the contraction. We do listen for a minute because it gives us a good range of how the baby's doing. And then we do this every 15 minutes, so we're not disturbing you all the time. So in the first stage of labour, every 15 minutes for a minute after a contraction. In the second stage of labour, or if we perhaps hear something different, or we feel like you're getting into the second stage and want to listen a bit more closely, we do bring that closer together. And in the second stage, we listen every 5 minutes, as I'm sure you all appreciate. That's quite a crucial time for the baby. Now, for some women, listening in every 15 minutes perhaps isn't close enough. So there's lots of different reasons why people need continuous monitoring. Perhaps if their blood pressure's high, if they're being induced, if they've got complications like diabetes, perhaps if the baby hasn't been growing well. There's lots of different reasons. When you first come into hospital, we would listen to the baby for at least half an hour usually. It can be slightly longer. And I've got a belt here, so usually the transducer, when you're admitted, is on your tummy and it's held in place with this belt. But the good news is we've got great equipment for monitoring you that doesn't tie you to a bed or a machine. So we have some what we call telemetry machines that don't have the cables, and we have even underwater monitors, but this has to be used in the delivery suite because the birthing centres work with low-risk labours that need the intermittent listening to the baby. If you need continuously monitoring, your place will be in the delivery suite. So there is underwater monitoring available as well. So that's really great for those perhaps that have got uncomplicated but might have had a cesarean before. Any of the sort of reasons that would have stopped people in the past, and it's worth considering. But we must get a good trace on the baby. If we've got these other monitors on, but it's very difficult to monitor the baby, then we sometimes have to change and adapt what we do. Let's talk a little bit more about the pain relief, because most people need more pain relief to help them at some point in their labour. Gas and air is what it's called Entonox as well, so we both use both terms to you. This is a very safe form of analgesia that's used even at home. We bring it with the equipment that we come out to you when you're at home. We have it in the birthing centres, and we have it piped even in the hospital. And the good news is it's unlimited. It's administered by yourself, so you have level of control on how much you have. And I'm just looking around because I've got various bits to show you. The commonest way people administer it is with a mouthpiece like this. We have a filter on. And it's important that you start using it, inhaling it. So you suck the gas in through your mouth, and then you can let the air out through your nose or through your mouth as a valve, so it doesn't really matter. You need to start using it early because it takes 25 to 30 seconds to have any sort of effect on you. So you get that sometimes the timing cannot be quite right when you start using it, so sometimes it just needs to be perfected. But what it does is it creates this sort of lightheaded, perhaps distance feeling towards the contraction discomfort, or some people describe it as having a few too drinks too many, that little bit of a high. Equally, as long as it sort of takes a while to work, it does wear off pretty quickly. So if you don't like the sensation, then if you leave it a minute, the whole sensations will have gone. It can be given by a mouthpiece, face mask, like this. And some people prefer that. And it's probably best that way if you're feeling a bit sick, because one of the disadvantages of this gas is that, putting it in your mouth and sucking it in, it can potentiate a vomit. So if that happens, it's worth sort of having a bit of a break and then trying it again, perhaps with a face mask, to see whether the same thing happens again. It also can be used in birthing pools. It's also used for other things. So people that might find vaginal examinations difficult, it's safe to use. We sometimes use it as the local anaesthetics are being put in if any suturing's needed. So the gas and air can help you at that point. It's pretty good and used by quite a few people. The water is quite a common method of pain relief. One of the birthing pools is situated behind me. You can't see its shape very well, but it's a bit flower-like, really. It's got different curves around it. They are usually quite big. We've got ovoid ones in Wallingford, which is my place of work for the last 20 years or so. And all the units have sort of slightly different shaped pools, as we call them. A bath at home an average bath at home doesn't have the same purpose. You can't move around it so easily. The pools help with the warmth of the water, the buoyancy and support to your back, and the aid to your mobility. If it's something that you think you would like, it's worth giving it a go. If it's something that you don't really feel like, then I would personally say go with your feelings, but stay open to change your mind if you want to. It seems that you have the instinct in you whether it's something you might want. The temperature of the water is really important, because if you get hot, the baby gets even hotter. Babies don't like being really hot, so we monitor the temperature quite closely. We don't usually have it above 37. And actually, if you're feeling very hot and we monitor your temperature too, we might drop the temperature a bit. As the baby gets towards delivery, and if you're going to deliver in the pool, we then warm the water up a bit so the babies don't get cold after delivery. You don't have to deliver in the water if you don't want to. Some people think they can't use the pool if they want to be out or on dry land, as we call it, but that's not true. Some women decide to wear clothing. I recommend something fairly tight-fitting, because t-shirts become quite a drag after a while. So people often use bikini tops or two pieces you can wear, certainly until the baby delivers. There are knee pads to help for the kneeling position, because the bath itself is quite hard on the knees. If the labour slows down, perhaps it was a bit early, we do sort of recommend that you're in the active part of the labour before you get in. And I often say to women, if you're managing and you know that you're 4 or 5 centimetres, but you're coping with the contractions well, just hold off going in the pool. Use it when you need it, because you will need it. There will be a point where you know that you need something extra. Sometimes people have to leave the water. It's not the right thing for them. They want some more pain relief, or perhaps there's some bleeding, or perhaps the baby's heart rate is perhaps not right, and it might be better for you to be in the room on the monitors. So sometimes people start in the pool but have to get out. Even in the second stage, if it's your first baby, perhaps, if the baby is delayed and it's difficult perhaps for you to be effective with your pushing, sometimes it's worth getting out. If at any point, for any reason, you get out of the pool and then you want to get back in, that's also fine. We can top the water up and refresh it. The main thing when you're delivering in the pool is that your bottom needs to be under the water for when the baby comes out. So the beginning part of the second stage, it's fine, you can be in whatever position, but the midwife will be advising you and filling the water level up so that it's safe for the baby. The baby needs, if the baby's underwater, the stimulus to breathe will be suppressed. The baby will get its oxygen through the cord, and as the baby delivers into the water, the midwife, or the midwife and you, you and partner, you can reach under the surface and bring the baby out of the water. And once its face is out of the water, breathing will be initiated, and the baby doesn't go back under the water again, but the body of the baby is best nestled in the warm water to avoid it dropping its temperature. One other method of pain relief I'd like to talk about is something, well, there's 2 drugs. They're both based on morphine. One's diamorphine and one's Maternity. We use both. They both have a similar effect. They are an injection. They cause a drowsiness and relaxation. So they're used twofold, really. Sometimes people have a very, very long latent phase and they get exhausted. So sometimes morphine might be used then, so that you have to have a rest. But most commonly it's used as pain relief. Perhaps you've been through the other options. Perhaps you don't want an epidural, or an epidural is not suitable for you. And morphine, it can be very useful. It helps you have a rest. You might need your birthing partner or midwife just reorientating you when you get a contraction, because you'll come to, and then you'll relax and go off to sleep. You'll feel the contraction for a much shorter space of time. It lasts about 2 to 4 hours, and then it wears off. So ideally, we would like it to be not right at the end of the first stage of labour. The babies can sometimes be a little bit sleepy, though by no means every baby, and it's not necessarily related to the time of the dose. So they can be a bit sleepy. Sometimes feeding can be a little bit slow for a few hours, and but you're in the right place to have the baby, so we'll be watching it. It is a very useful form of pain relief. Epidurals we're going to talk about at another time. So perhaps I've been going on a bit much, and you have some questions that we could go on to, and then we'll see whether or not we've got time for the second stage and third. Okay. Wendy's going to take off while I just get my papers sorted out.
Okay, so the first message from Shannon is that you're a young mum. You're currently 25 weeks pregnant and not due to August. Do we think that one birthing partner rule will still happen then, as you want your partner and mum with you? Shannon, we really don't know what's going to happen. We're taking each week as it comes. When we're at the point, we're going to hear what the government says today in terms of, social distancing. I haven't heard the news. They've perhaps announced that already, but we are very much looking at it on a week-by-week basis, and we will make sure that you're aware of the changes if they happen. We're hoping by August things will be back to normal. And we will do what we can, but I hope you've said that you are understanding if it's not. For people who really are due now, we've said to them, we're more than happy when you're in labour if you want to FaceTime or WhatsApp, screen call for your mum to be there as well, or your partner to be there if it's your mum that's with you, so that you still have that contact there. You can still see them, they can still see you, and help to support you just in a very different way. You had a very similar concerns. Hopefully that's answered your question. I think the last day of May, I think it is very likely we will still be on the one birth partner rule. Annalise, you've asked, can your partners still stay during the golden hour, that fourth stage of labour? Yes, they absolutely can. Your partner may be a man, your partner may be a woman, whoever they are, it's fine for them to stay with you for that time, because it's all part of how you're all bonding together. Marisa, you've said if you have pelvic girdle pain, is labour more painful? Marisa, when you have pelvic girdle pain, you have to be rewarded in lots of ways for having to go through pelvic girdle pain in pregnancy, and your reward is that often labour and birth is much quicker when you have pelvic girdle pain. The reason you have that pain is because the ligament at the front of your pelvis is a little bit more relaxed and your pelvis is more mobile. And obviously, if your pelvis is a bit more mobile, there's more space. And what we find is that women tend to labour and birth much quicker when you have pelvic girdle pain. And so it can be an advantage to you. It's not necessarily any more painful in terms of your pelvis, and you're already having to put up with quite a lot of pain with it. And for those of you that want a quick labour and birth, please don't wish yourself to have pelvic girdle pain, because actually that's not very nice thing to experience. Maisie, you've raised a very good point. You said, can you use a TENS machine and still use a birthing pool? You can't actually use the TENS machine in the pool. It would have to be removed to go into the pool. And if you came out of the pool, your back dried and it reapplied. But no, it doesn't work within the birthing pool. Gabriella, you've said, would you recommend it before a contraction, or can you have it during? I'm not quite sure what you're referring to. In terms of pain relief, you use it might be Entonox. So the Entonox you absolutely use during the contraction. So as the contraction is building, do you remember Nikki showed you those peaks? So as the contraction intensity is on its way up, that's when you start using the gas and air. And then after the peak has gone off and it's becoming less so, that's when you take the gas and air away from your mouth and breathe air, so that you're feeling that you can recover and get in the mindset again for the next one. A TENS machine is obviously on the whole time, and it's just the boost is used during a contraction and then the boost is relieved afterwards. So I think that might answer your question, but if not, please ask again. Elvira, you're saying that you live 30 to 40 minutes from the John Radcliffe, and how can you make sure that you'll not arrive to hospital too early for labour and you'll be sent back home again? Elvira, that is a really common concern, and part of me is a little bit curious that maybe perhaps people are leaving it a bit late coming up to hospital at present, because of that very thing. You know, people don't want to be coming in and and then going home again. You do have the capacity, if you live near one of our midwifery-led units and it is suitable, there may be the option for them to see you, talk to your midwife to see if that's an option. But generally, we say, if you remember when we talked yesterday, and you could look back at the film to see, we talked about those contractions becoming regular. So when it's your first baby, when they're happening every 3 minutes, really, they're lasting, 45 seconds or more, and they're happening regularly, and they've been in that regular pattern for about an hour, then that's about the right time for you to contact us. If it's your second and subsequent baby, actually every 5 minutes is probably all right. But as Nikki was saying, if you had a really quick birth first time round, then actually when they're every 7 to 10 minutes, we might want to see you at that point. But it's about those nice regular contractions, and each one should seem as strong as the last one. So I hope that helps you. You wondered, Caris, you wondered whether it'd be possible to use the pool even if you're high risk with epilepsy. Caris, I'm sure you're aware when you have epilepsy, we discourage women from using baths, and it is the same with the birthing pool. So we really wouldn't recommend that you use the birthing pool for that. We do have showers in our bathrooms and things that you could go to and use that, because the warm water on your back can be helpful, but we actually wouldn't recommend you use the birthing pool. Marta, are you live from one of the birthing rooms in the Spires? Yes. This is Wytham room. So this is our pool room. The reason it's in the Spires is just because that's where my office is based. So that's why I'm doing most of the feeds from here. Tomorrow I will be doing the feed from Delivery Suite, hopefully, so I can show you a little bit more of Delivery Suite. And Marta, if you go back through the Maternity Voices Facebook page, you will see that I did do a very quick tour of the Spires in one of the sessions that I did. I can't remember, it might be Wednesday last week, something like that. Have a look at the date. Oh, Gabriella, you've clarified it was about the gas and air. So yes, you are going to breathe that during the contraction. Lou Ann, you said you're booked for induction at 39 weeks. Anything I should be prepared or more organised for? Lou Ann, it'd be really good for you to tune in tomorrow, because we're going to go through induction, and hopefully you're going to meet Di, our induction midwife, tomorrow, and she can answer some of those questions then. Ella, you've asked, why are enemas no longer given before birth? Ella, we don't give them routinely now, because we find that in the majority of cases, a woman's body naturally prepares herself for labour. And I think Sarah talked about it yesterday in terms of, you may notice that your bowels evacuate quite a lot the day that you go into labour, and that your body is clever enough to do it itself. Very, very rarely, if people suffer from constipation, we can be aware when we examine you that you may benefit from an enema, so we may do it then. But we don't do it routinely, because actually it's quite a barbaric thing to do in labour. You know, if you've ever had an enema, you have to hold on to the sensation to go to the toilet and not open your bowels, because you have to hold on to the substance so it can soften the stool to pass it. So that's quite intense to do that while still experiencing labour. And if it's not necessary, we don't want you to do it. Just like we don't shave anymore beforehand, because that isn't helpful. And in this day and age, many more people take care of that side of things themselves before they come in. I hope that answers your questions. And I'm going to pass back to Nikki, and she can talk to you about the second stage of labour.
Right, so we travelled through our first stage of labour, and some of you might read about something called transition. So this is not so distinct. It's basically means that your contractions are strong and you're starting perhaps to feel sometimes like you can't cope. You might be starting to feel some pressure. Often it's feeling like a pressure in your bowels. Some people actually say they want to get up and go home. It's sort of like a response to what's going on. And we give lots of reassurance at that point, but it's often in that last hour or two before you're ready to push. Now, some people don't actually experience this at all. They naturally transition from one to the other. It can be very short, or it can be a bit longer for some other people, but you might well read about it. So that's what I wanted to just mention it to you. So the second stage of labour is often proceeds naturally. Your body will change the contraction tone. The contractions change in nature themselves. There's much more of a sort of downforce to it, and you're going to feel it yourself. And we as midwives sometimes can actually hear it in the differences in your breathing. Often at Wallingford, you don't have to be in the birthing room with someone to know that they're reaching this second stage. So the baby in this stage has to travel down the vagina. Now, I showed you that curve with the sacrum and coccyx, and that creates a curve that the baby also has to travel through. So although it's quite a short distance for the baby to come out, it does take sort of time, because there's the rebound from the tissues. And they're, you know, if it's your first baby, they're stretching for the first time, so it can take a bit of time. At the beginning of the second stage, most people will feel like they want to push their baby out, or they want to have their bowels open. Now, some people don't. And there can be a period at the beginning of the second stage where actually it's more fruitful to actually do some walking around and different positions, have some hydration, and let the body do its own job before you start the exertion of trying to assist the contractions to deliver the baby. Or perhaps you've got an epidural in which case your sensations are reduced. So we now let the baby, if the baby's well, the baby descends, does the first part of the second stage itself. Now I have a model here. I've got a knitted uterus and a baby. So I just wanted to sort of, oh yeah, probably, yeah, my assistant here. Obviously, that's sometimes the way we see the baby. You automatically give a push, and we can sort of see the top of the baby's head during the contraction. If we can see the head, there's absolutely no cervix there. We don't need to do anything. Sometimes in the course of your labour, we need to just check everything's right. So one of the things we do is assess progress in labour. Now this happens perhaps every 4 hours, maybe a bit longer. If there's a reason, they're sometimes a bit shorter. But it does involve putting our fingers into the vagina and feeling the cervix, how much is there. And sometimes we get a surprise and you're fully dilated at that point. And the midwife will then advise you what's best to do. It sort of depends on how you are, how high the head is, and then you'll make a plan of whether to sort of do some walking around different positions or actually to start pushing. So to start with, when you're pushing, you're going to feel like the baby's coming out of your bottom. That's the sort of direction of your push, and it takes a little time sometimes to get used to it. You only do some pushing while you've got a contraction, because the force of the contraction and you pushing help the momentum. It's quite difficult to push baby without contractions, and it won't descend. But to start with, what happens is that you give a push and we see a bit of the baby's head, and then in between the contractions the baby disappears up again, and then with the next contraction it might do the same journey and go back. But eventually what happens is it stretches the tissues in your vagina, so it gets much easier for the baby to sort of descend. So we start seeing a bit more of the head, and you may find different things work, different positions. And I've just got a chart here that gives you some ideas. So sometimes the kneeling one down here is quite common, or kneeling with, if you happen to have, after this COVID, have 2 birth supporters, or the midwife could take one of those, that sometimes helps. We often have partners supporting you. That's quite hard to sustain for a great length of time, but sometimes we have the partner sitting on a chair with you kneeling in front of them. That's somebody delivering in the pool. And behind me, there is that purple object there is one of our birthing stools, and there's some handles there. And so sometimes that can make the difference. So perhaps you've been doing some of the other positions and it's worth trying. Wendy's going to produce a baby for me now. So it is quite solid. It gets your body in the right position, and it can be helpful. It can be uncomfortable after a period of time, so you might have gone on the birthing stool and then you perhaps go back to kneeling over the beanbag. So chopping and changing. I sometimes also get women standing with one foot up on a short footstool, so that it changes the way the pelvis is gaping, so that sometimes can make a difference. Some people are lying on their side. Some people deliver lying on their sides. That's the position was used in the old days, but sometimes that will encourage the baby down. Something sometimes is different in a different position. We don't know why. During this stage, the midwife will be listening to the baby quite frequently. She might be the only midwife in the room at this time, but as it approaches delivery, a lot of midwives will call for a second person to be around. Now, if you're in one of the peripheral units, we're not very far from each other, so we're usually outside the door, or we come in and help do some of the writing for the midwife. So there's usually 2 people around, or one person with you and somebody very close to hand and there for you if you need them. So the baby is now getting lower and lower, and it reaches the point where actually it doesn't slip back, or it starts slipping back much more slowly, or it stays there. So when it's like that, oh God, sorry, it's the face. So we get to the head, it's the back of the head that comes out first. You get to a point which is called crowning, and the baby is really nearly here at this point. It's a point where you feel there's a lot of burning down here, a lot of discomfort. A lot of women just want to give that extra push to just push that baby out really quickly. But actually it's useful to just pause at that point and just take it a little bit slower. One thing we find really helpful is to put warm compresses around the skin down here. It takes some of the uncomfortable sensations away and helps that skin stretch. And you'll have had a conversation with the midwife. She'll be talking to you about how to deliver. You might not want to know what's going on, or maybe you'd like somebody to tell you when things are right and what's happening with you. We'll have that conversation, but there'll usually be a conversation about the midwife saying at some point she might get you to pause if things are happening a little bit quickly, and then she'll get you to give a push and she'll guide you, because the baby will gradually then ease out. And as the head delivers, the face comes forward, and then sometimes you give an extra push, and then we get the chin delivering. And then there seems like a huge pause, because actually the rest of the body has to do a few different turns. So what will happen is you'll see this baby's head do a 90-degree turn if you're watching. So your partners might be seeing this. So the baby does a 90. Now that's a really positive. Now the shoulders are in the longest bit of your introitus. So the shoulders are in the sort of longest diameter to help the delivery. And then what happens is usually there's a bit of a gap waiting for a contraction. If there's gap goes on a bit long, I just give the tummy a little rub, because that usually sets the contraction off. Then with the next contraction, when you give a push, the midwife will gently give traction on the baby down, so the top shoulder comes out. And once that's released, she'll lift the baby up, and it comes out quite quickly, the body, in one. And the baby usually have described how you want it. Most people like the baby delivered to them, and we try and keep the baby's skin to skin. So the baby will be wet, so they'll be dried off to start with, and then perhaps have some covers put on it. The baby's still connected to you at this point. The midwives will be assessing the baby, seeing whether the breathing's coming. It can take a minute or two for the baby to get going. Sometimes they cry as soon as they're born. Sometimes they just take a minute or two to get going, and you'll start seeing them snuffle and see their breathing perhaps become a bit more regular. And their colour is quite often bluish when they come out, and you'll see the colour change to a more pinkish colour, and they're snuffling around. So, and you've delivered your baby. It's often, we're all pretty emotional when the baby's out, and we're all very happy with everything. And then we try and leave the babies skin to skin as much as we can for the time. We also usually leave the cord connected to the placenta at this time, because the circulations are still continuing, and the baby quite often benefits from having that extra bit of blood that's in the placenta. But at some point the placenta will need to come out. That's the third stage of labour, and there's two ways it can happen. One is to have it without assistance of hormones, or the other way is to have assistance. So the first one is called physiological, and the second one is called active management. There are reasons to have active management for certain conditions which make you more prone to bleeding, such as high blood pressure. If you're anemic, where you would desire a less blood loss, then active management is a better source. If your labour's been very slow and it's needed some assistance, that's certainly reason to actually have active management. For some women, there's no risk factors, the labour's gone well, and they prefer to let everything to wait. So then it can take up to an hour if you're letting the body do the work. And in that hour, the baby is cuddled next to you, stimulating hormones. If you're going to breastfeed, we would try and breastfeed the baby, because breastfeeding encourages the same hormone. That's what delivers the milk out. So, it stimulates increased oxytocin. We watch for any bleeding. We watch for the cord lengthening. That's a good sign that the placenta is starting to separate. You might start feeling a fullness again in the vagina and feel like pushing, and then the placenta delivers with you pushing it out. The cord might carry on working for half an hour, and then you might say, perhaps change your mind and think, I want to deliver the placenta. So the midwife can cut the cord to separate the baby at that point. And if the placenta isn't ready for delivery, you can then have an injection of hormones if you want, or you can wait a bit longer for it to work. Those of you having the active management, we deliver the babies, and then we would give you the injection in the leg. Now we can, if there's no problems, we can delay that a short time, but if there's certain risk factors around, you might be better having that, because it takes several minutes for those hormones to work. And then as the circulation gradually finishes, we separate the cord, and then the midwife will be feeling your tummy to check that the placenta's separated, and then she'll place her hand just above the pubic bone and lift upwards towards your chest, and she'll have a hand on the cord and just do a steady pull to deliver the placenta and the membrane safely. And Wendy's just delivering the placenta. It's quite a large, sort of large side plate size, thick. The cord's usually somewhere around the middling section where it's a bit thicker. There's two membranes that come out, and if any of you want to see your placenta membranes, they're quite fascinating. For those of you that have, that are in there, it's useful to see. I think it's quite interesting to see where your baby's been. But the placenta will then be disposed of. Those of you that are rhesus negative, we take some blood from the baby's side to check your baby's blood group before it goes. So you've had your baby, and perhaps there's some more questions there to go through.
Questions? Okay, sorry, I've come on too far. Let me just go back a little bit. So we have Gabriella. In the GR, is there a midwifery-led only floor? Yes, Gabriella, this is the Spires that we're in just now, which is the midwifery-led only floor, which is on level 7, and our consultant-led delivery suite is on level 2. And if you do have to transfer from one to the other, we do have a lift that's designed for us and isn't shared with the public, so that we can get you down there in a timely manner if it's required. Matilde, you said that you've got a section plan for tomorrow. What protection will myself and birth partner be given in theatre? So Matilda, in theatre, everybody in theatre will obviously have on their protective clothes and their masks and gowns and things. I'm not sure that you're at increased risk from us because we're all covered. So I'm not sure if they're asking you to wear masks or not. But what I will do is I will clarify that and post that for you on the Facebook page, because I don't want to give you false information. But we will absolutely be wearing gowns and gloves and masks. Gabriella, you've asked, is there an expectation for women to come shaving? No, please, you don't have to. It's just that some women choose to. But in years gone by, when we used to give enemas, we used to shave everybody when they were in early labour as well, and we've stopped doing that practice because it's not necessary. It's just that some people are
anti-hair, really.
Anti-hair.
We don't mind, though.
We don't mind. Annalise, you said you have an anterior pelvic tilt. Will this make it more difficult for you giving birth? No, your baby will find its way through your pelvis, Annalise. Please don't be concerned about that. Gabriella, you said, can you still take gas and air as the baby's head is crowning? Of course you can. You know, it may be if you're using it too much and you're not pushing and the midwife wants you to push, she may encourage you to come away and have some fresh air for a bit and try some pushing without it. But that's only if she thinks that baby needs to be born and perhaps you're holding back a bit, because some people do. They go, no, I don't want to do this last bit, and they hold back and they just go on their gas and air and you can't get them up for air. So sometimes we encourage them to come off it. But at that point, we've built a relationship with you and we very much are doing things with you. So please don't be concerned. And I think that seems to be all the questions that we've got. We have given you such a whistle-stop tour
of labour,
through the first, second and third stage of labour. I hope we've answered most of your questions. And then tomorrow we're going to cover, like I said, I'm going to try to be based on delivery suite. And we're going to cover some of those things that you might want a bit more detail about. So I'm hoping Jenny, one of our anaesthetists, is going to join us and talk about epidural. Hopefully, depending on what's going on, I might be able to show you another room on delivery suite and perhaps the theatre if anybody's interested, but I obviously can't promise. And that might be not something that you want to see anyway. But we can talk about instrumental birth because I know that quite often drives a lot of questions. And we'll talk about induction and caesarean section as well. So, you know, we're not doing it to frighten you. And if you choose not to listen in, that's absolutely fine. We just want to provide the information because everybody makes different birth choices and things happen in different ways for other women. And like I said, you'll hopefully meet our induction midwife tomorrow as well. And she'll answer some questions. So just check, looks like we might have had something in. Ooh. Emma, you've talked about having an episiotomy for your first baby. Does this change the risk of a tear for a second baby? Emma, I presume you had to have an episiotomy for your first baby. It can be for different reasons. That's the cut that we can make to help make the space a bit bigger for a baby to be born. That does create some scar tissue, and there is a chance that the scar tissue may give a bit, but it won't necessarily go to the same extent that it did last time round. And you know, Nikki was talking about those warm compresses and things that we use to help with the delivery of baby's head and trying to get baby's head born much more slowly, especially second time round, will reduce the chance of you tearing.
Did you mention perineal massage?
I didn't, but that's a really good point.
If you look on the Oxford University website and the information, there's an information leaflet in Maternity about perineal massage. Now, some people do find this difficult to do, but certainly in the last 3 or 4 weeks of pregnancy, especially if you perhaps had a larger tear or an episiotomy, it can be useful to try and do some massage. It doesn't have to be done particularly in a way, though it is described in the leaflet. It's a case of putting your one finger slightly inside the vagina and one on the outside and gently stretching the tissue down there, using usually some sort of oil or lubricant to facilitate this and make it less comfortable. It's obviously can be quite difficult to reach at that point. So sometimes if you can't, then a partner, if he is willing, can try to do it. Or sometimes people find sitting on the toilet as a really easier way of doing it. It's an option there for you. to try, and we do have quite a lot of success with people second time around. But really the important thing is listening at the end to the midwife, just following the time, and even if you do a tear, it's rarely as much as the episiotomy first time, but you can only do your best with holding the speed and having the compresses and things there.
Thank you. Vicky, you've mentioned, can you go into the pool if you're induced? Vicky, as long as you don't require to have the hormone drip as part of your induction, or with these, sorry.
Yeah, that you can use the pool. Your labour proceeds. You can come to the spas if you meet the criteria for the spas, even if you've had the hormone gel, or your water's broken, which is the second stage of induction, which will be described tomorrow. It's unfortunate that the oxytocin drip can actually means that you need much more closer monitoring in labour that perhaps we can't do in the pool. The drip is really difficult to manage with your hands with water and things as well.
Great. Marta, you've just said, I'm glad you're enjoying the sessions. You said, did you say you had a floor mat, a yoga mat? I don't know if you can see. I'll try and hold
it's quite a big one here.
They come in various shapes and sizes, but this is one of our mats up here that we use. And downstairs on delivery suite, we have some smaller mats, rectangular shaped green mats that are quite thick. So you can use those. And
Wallingford, and I'm sure the other birthing centres, we have mats too. We have bean bags, we have balls. We don't bring anything to home delivery, but if you're planning a home delivery, we usually sort of talk about what you can use around the house to help you and help you get prepared for that.
And thank you all very much for your support. We are overwhelmed and pleased that we could be doing anything to make this time for you, as easy as possible, and give you the information you might otherwise have missed. So we hope that you can join us tomorrow for another session. I'm sorry, it will probably be me again. I'll try and find somebody different so you don't get me constantly. But thank you very much. Have a good afternoon, and we'll catch up with you tomorrow. Thanks,
Thank you.
Nikki.
Bye-bye.